Hello, this is a pleasure for me today to be here and share with you the latest data regarding immunomodulating therapies in COVID-19. You can see here my declaration of interest as of today. And first, to set up the scene, I would like to remind you of why we should use immunomodulators in a viral disease such as COVID-19. Well, you see on this picture from this very nice review published in 2020 by Astrid Vabre, a French virologist, that in subgroups of patients, a delayed or suppressed type 1 interferon response has been seen during initial infection. And there is also a viral replication that triggers hyperinflammation state with an influx of activated immature neutrophils and inflammatory monocytes and macrophage. And this is accompanied by an activation of complement and increased risk of thrombosis. That's why acting on the specific inflammatory pathway might stop the development of cytokine storm, and that hypothesis has been shown in many studies. So when to use immunomodulators? If we look back at this very well-known picture of natural history of COVID-19, we see that there are mainly three stages during the infection that might lead to severe COVID-19 and death ultimately. First, the stage 1, which is called the early infection with the maximum of the viral response phase, followed by phase 2, the pulmonary phase, and then the stage 3, hyperinflammation stage. And we can act on this hyperinflammation phase at the end of natural history of COVID-19, just before the COVID-19 disease becomes severe, and of course before death. And at this stage, many groups of treatment can be used as for modulating the immune response, especially corticosteroids, human immunoglobulin, but also IL-6 inhibitors, IL-1 or 2 inhibitors, and JAK inhibitors. I will address the interleukin-6 inhibitors, interleukin-1 inhibitors, the JAK inhibitors, and the corticosteroids during this talk. First of all, it's always very important to remember that dexamethasone has been called a game changer at the early phase of the epidemic, and especially in June 2020, where the recovery trial with thousands of participants has shown that using dexamethasone in patients on oxygen therapy, but non-invasive oxygen therapy, had decreased mortality by 20%. And in patients were intubated or high flow oxygen, mortality decreased by 35%. And that was not the case in patients without need of oxygen. In this meta-analysis of dexamethasone, which has informed the WHO in its guidelines for broad use of dexamethasone, dexamethasone has become the standard of care in July 2020 with the decreased mortality still high in some groups. That's why we call the effect of dexamethasone a differential effect. And there is a slight risk of infectious complications. That's why dexamethasone should be used in purpose only in patients who are dependent on oxygen. Regarding now the anti-interleukin 6, which I call the newcomers, the WHO commission meta-analysis has been done on 27 trials. You see more than 10,000 patients, of whom a little less than 3,000 died by day 28, and the group of comparison was standard of care or placebo. And you see that in the wall, the 28-day mortality is decreased with anti-interleukin 6, anti-interleukin 6 like tocilizumab or sarilumab, but the effect is more associated with tocilizumab. This is also the case in patients regarding progression to mechanical ventilation, ECMO death at day 28. And there is also a greater effect of tocilizumab when associated with dexamethasone. That's why the WHO has said that the treatment by interleukin 6 receptor blockers like tocilizumab or sarilumab should be used in patients with severe or critical COVID-19. But regarding the association with corticosteroids, it is recommended that patients with severe form of COVID-19 should be treated with the association of corticosteroids and interleukin-6 receptor blockers. You see at the bottom right of the slide the question that should still be answered regarding the use of interleukin-6 receptor blockers, safety data in terms of nosocomial infections, because there was like a safety signal regarding the number of bacterial infection associated with the use of such drugs, the necessity of that kind of treatment with non-severe COVID-19, which has not been shown so far, etc., etc. If we switch to anti-interleukin-1, you see that I call them the comeback. Why? Because before we had big clinical trials, we had the meta-analysis of 15 small trials and prospective cohorts, and you see that the number of patients in a wall is quite small, 700 patients on Anakinra, for example, and less than 2,000 patients in control group. And you see that there is a positive effect of Anakinra in this meta-analysis with safety signal, although not significant, on liver enzymes elevation and thromboembolic risk. Very recently, a study has been published on a good trial based on the use of a biomarker to see which patient could really benefit of Anakinra. And when using a biomarker called SUPER, which is a soluble urokinase plasminogen receptor, which is also a marker of danger-associated molecular patterns that has been shown to be associated with severe course of COVID-19. So patients with this biomarker with a level above 6 were randomized in two groups, one receiving Anakinra and one receiving placebo. And you see that the odds ratio of death or mechanical ventilation was in favor of Anakinra. So maybe this is the beginning of the use of biomarkers to select the immunomodulators, which is adapted to the situation of the patients. Regarding now the anti-JAK, we have now the confirmation of efficacy of anti-JAK on mortality and especially Baricitinib. A lot of drugs were evaluated at the beginning of the pandemic, Baricitinib, but also Loreceptor, but most of them were through underpowered trials, or mainly prospective cohorts. Powered trials have been published with Baricitinib, but associated with remdesivir, and the effect of the combination was positive on the mortality outcome. And there was also a tendency of a significant effect of Baricitinib, but not ruxolitinib on mortality. And very recently, a good, well-powered trial with a good design has been published in Lancet Respiratory Disease, and there was a randomized trials of patients with oxygen therapy and corticosteroids. And you see here that the patients treated with this combination included Baricitinib had a positive impact on mortality. This needs to be confirmed with other trials, and that's why a huge pan-European trial has been designed called the Bari-Solidact within EU Solidact, which is a pan-European platform on adaptive trials as a response to pandemic. Now, Tofacitinib, which I call the new kid on the block, because a small randomized trials has been conducted in Brazil, showing a positive effect of Tofacitinib on death or respiratory signal, respiratory failure with no safety signal. And the effect of Tofacitinib on death or respiratory failure was driven by the gender, age, the presence of glucocorticoids and the number of days after symptom onset. So to conclude this short presentation, a few take-home messages. There is no inflammatory drug that have been better than corticosteroids in reducing risk of clinical progression to date. Timing definitely matters, neither too late or too early. Tocilizumab have been extensively evaluated now, and there is a confirmation of a positive effect on mortality, especially when associated with corticosteroids. So probably tocilizumab and corticosteroids should be considered as the new standard of care in oxygen-dependent COVID-19 patients. Anakinra is the first drug whose prescription can be guided by biomarkers, so there is a need for defining the right recommendation for Anakinra. And Loreceptor, there is a confirmation of its efficacy in patients with oxygen therapy and corticosteroids. So what is missing now? Probably a strategy of choice of immunomodulators in severe COVID-19. Thank you very much for your attention, and I will be available for the Q&A session.